fascinating presentation. And now we have almost 10 minutes for discussion, so I hand this to Alzbeta.
Okay, so do we have questions? If not, I would have a question, but please. There is. Okay, and
hi, thank you. That was a really stimulating set of talks. I've got a question for Bernhard, which is that in terms of the needs-based assessment, sure. Quite often in clinical practice you see two individuals at similar levels of disability who have very different experience to that disability. So one might be very frustrated by their problems and the other not at all. So for whatever the reason underlying that is, does the needs assessment differentiate between people's experience?
Can you hear me? Yes. Okay. So I think you're pointing to something really, what motivated the development of need-based instruments. That there is a wide range of reaction to from a, if you like, medical point of view or from a rater perspective, and a similar extent of impairment. And I think the idea of these instruments is that indeed you distinguish that and can guide your interventions in such a way that is helpful for a readout that would aim at, if you like, equilibrium or fulfilling needs that are of relevance for the individual. What it would, from my understanding, not do is deconvolute how these differences come about. Yeah? But that might be subject to additional studies and research, but I think it is helpful to reflect the differences that are obvious in our clinical experience and practice, and guides in an individual where we may want to intervene.
Okay, thank you, Bernhard. Do we have some more questions? Okay,
Also,
please.
I could not agree more with you and your wonderful talk about the influence of stress on Huntington's disease. This is something that John Whittier, Woody Guthrie's physician and psychiatrist, published 50 years ago. So we have to really educate the HD community that stress is relevant both for onset and the progression of disease. And thank you for mentioning the structural basis of these problems. I remind you of the findings I published in the 1980s about the involvement of limbic structures in the brain.
Thank you very much for that comment. Thank you.
Okay, then we can have another question, please, in the...
Yeah, thank you very much for fantastic panel talk. My question is, like, when you're talking about neuropsychiatric symptoms or just psychiatric symptoms, and you're explaining that the mechanism is part of the Huntington disease itself. So I wonder if you go upstream, is everything linked with the mutant Huntington gene? Or are there other mode of actions which are contributing to the either psychiatric symptoms or cognitive symptoms? Or is it part of the same equation as you go upstream?
Thanks. Well, helpfully, Peter Holman's partly answered this. There are influences for polygenic risk scores, so things that we know from the general population that influence the development of this, but also from those two papers that the CAG repeat also has an influence independently of that. So the answer is it's both at a genetic level. Peter's got his hand up.
Yes,
Don't ask
Peter.
me something about that, Peter.
So thank you for the shout out, Duncan. Yes, so we did have a look. I work in a psychiatric genetics department, so I'm interested in psychiatric genetics. So we actually found that, there was certain psychiatric symptoms in HD did sort of share some of their genetic risk with similar psychiatric symptoms in the general population. So, for example, schizophrenia risk was associated with psychosis, and major depression risk was associated with depression. But obviously, this is only a start. We didn't use very sophisticated phenotypic measures, so I want to go back and analyse that more properly. But now I've got the microphone, can I just ask a question? Sure. So I was interested in the sort of correlation between sleep disturbances and psychiatric symptoms. So I guess my question is, what's the direction of causality here? Is it sleep disturbance causing symptoms, or is it the other way around? Or is it both, in fact?
I think that's a really good question, and Roger Barker just published a really interesting review that I encourage you to read, who was really discussing what's the hen and what is the egg, and really arguing that the HD we have a special possibility for Huntington's disease maybe to dissect these things out, and I think this is a key question for us to investigate now.
Okay, thank you. So we have one more, I think we have one more question, please.
So there are a couple quality of life instruments already available, HD QOL and HDQ Life.
Yes.
What's the difference between those and the one that you're developing?
Mm-hmm. So most of the instruments that are out there are health-related quality of life instruments. And the construct, as I was trying to explain, is a different one underlying those. It's a profile, if you like, of abnormalities, as opposed to one index for the alteration that you see. And the difference is the difference in perspective. And as I was trying to point out, it's a more patient-centered perspective that is strived at with the need-based quality of life assessments. These things might be complementary. I'm not, and we will have to gain experience with the new instruments to understand their real impact and their real value. But I think, and that was the motivation for us in part to develop it, we are interested in evaluating the impact of interventions that are not by default pharmacological in nature. And I think that's a big lack in our armamentary, if you like. To what extent the potentially high sensitivity of these need-based instruments may inform the evaluation by regulatory authorities and us as clinicians is something that we need to explore once we have the instruments available.
Thank you. I see 1 minute left, so we could manage one more question. Here on the left side.
Just as a follow-up to the discussion of need, Qual, thank you very much, Bernhard, for this initiative. I think there's one more difference with the old measures and this measure. Just having a glimpse on the screen, the sentences are short, patient-friendly, and there are just two options to choose from. I have been struggling with SF and other health quality of life measures for years, people choosing answers really random sometimes. And this measure looks really friendly, not only for pre-manifest people, but for people who have cognitive issues. Thank you.
So, thank you for these very nice closing words. Thank you all speakers. And
I'll be very, very quick. Sorry, if I can just ask one last question.
I'm sorry, I didn't see you.
Hi. Thank you very much. That was very interesting. I think I just had a very quick question regarding some of the schism there seems to be in the way we approach certain things. So we started off with a very interesting talk about a patient-centric quality of life measure that focuses on patients' needs and what they need to lead a fulfilling life. And then we had two talks about psychiatric difficulties from a very biological perspective, and there was a sheer lack of any sort of psychological development in that sense, psychological theory. We know that we have, for example, emotional regulation difficulties stemming from attachment difficulties, which can be very understandably part of the development of people with Huntington's, not just people who saw their parents grow up with Huntington's, but also who develop themselves. So do you think that it is now time to start integrating these sort of talks in our approach to psychological and psychiatric difficulties in the condition?
Okay. Who would like to comment?
Yes. Do it.
Okay. We are unfortunately out of time, so we have to finish the discussion. We can continue over the break. Thank you, everybody, for listening to us, and thank you all speakers for these wonderful, great talks.